What I do want to say is once we've shaped the two canals, there is a kind of beautiful type of symmetry we can see with this tooth. So hello, welcome to this week's clinical case. And this is one of those kind of clinical cases where you get in and you kind of second guess yourself, because when we look at molars and we can only see two orifices and there's an apparent only two canals, you're thinking to yourself, this is a huge red flag, because I think more often than not, you're going to be getting three canals for sure. And when we come to look at the clinical case later, the pre-op radiograph, you can see there's a sign of only either one or two canals. But before we get into that, what I would like to say is that when we look at the metrics of the channel, only 50% of the people that view these videos very regularly are non-subscribers. So if I could ask you just to do one thing before we start, it's quick, it's easy, and it's free. It's just hit that subscribe button. And if you want to support the channel even more, we've got a membership program. The membership program is run by YouTube. You go to our main page, I Love the Pulp page on YouTube. You'll see it right at the top of that page. And it's a small monthly fee. You get early access to content. So if you like these videos, I usually run about 3 or even 4 weeks ahead. So you get 3 or 4 weeks worth of videos early. And we also have exclusive content. We've got a fantastic endodontic access lecture on there. That's based on a hands-on lecture that I usually do face-to-face. So we'll get on with the case. This is a upper right 7. And I suppose in a way, when you look at this immediately, you think to yourself, well, this tooth is in a very, very poor state. But actually, if you look at the rest of the mouth on this x-ray, you know, he's got a unrestorable upper right 6, and you know, in the rest of his mouth and clinically, he's not got a lot to go with. So in this case, despite the upper right 7 being quite badly broken down, he'd insisted that we try and save this tooth. And you know, you could argue that this tooth, when root canaled, probably won't last as long as another tooth which had more tooth tissue. But given the you know, the clinical situation and the patient's consent, he's decided to try and save this tooth. And what we haven't got on the video is the restorability check. So I had this patient in for half an hour appointment where we kind of built the tooth up. We got to remove the decay to see if the tooth was restorable, and it was dressed by me. So we take up the case here by, again, always placing rubber dam. This can be quite difficult on a small tooth. But when we come to access the tooth, this is nice and easy because I have access to the tooth. So I've put a composite sort of wall around and a bit of GI in the middle. And then I have dressed this with PTFE. And I always say, you know, cotton wool always gets a little bit stuck. But in this case, you know, PTFE isn't foolproof. So here, I like to call it the spaghetti approach. And essentially, I'm pulling out the PTFE as if I was rolling some spaghetti on my fork. And again, you know, not all dressings are completely cut and dry. You know, I think what's happened here is I've not removed enough of the temporary, and you know, we just do a bit of refinement here, and straight away we notice that are two obvious orifices. Okay, so again, red flag. I'm thinking to myself, this is unlikely, despite the conical looking shape on the x-ray. And in the first instance, what I think is this is a palatal and an MB, and I'm going to do a little bit of investigation for a DB canal. I'm using a fast handpiece here, just have a little look around. And again, I'm sort of using this fast handpiece in the distal aspect. But if we kind of pause the video here and I annotate on the picture where I think the DB could possibly be, it's kind of this area here. But don't forget, this is a conical shaped tooth, so we've got to be really, really careful that if it is genuinely two canals, we don't perforate. So what I'm going to do is I'm going to do a bit more investigation. I'm going to look for this DB by using lots and lots of irrigants. That's really, really important. I'm going to activate the irrigants. And once I've kind of fiddled around, if we pause the video again, we can see here that, you know, we're in the kind of a bit of a danger zone here. So I've mentioned in a few of my videos about the law of canal orifice location. And when we're looking for canal orifices, we're looking for the junction between the walls of the pulp chamber and the floor. And the way to sort of distinguish between the two kind of surfaces is the floor is always darker than the wall. And if we have a little look in this kind of area annotated here, this is quite white. Okay, so this is a bit of a danger area. This is where I'm removing the pulp chamber wall rather than removing like any kind of different tissue. So I am not convinced there's a DB canal here. That's not to say if we look really, really close, the DB and the MB are in the same orifice. But again, it's we're just trying to have a little think about this and just got to be super, super, super careful. So what I'm going to do is I'm just going to do more irrigation, and I'm going to go for the working length of the buckle. This is found to be 19.5, and I'm going to do the working length straight into the palatal. In this case, I am also thinking in my mind, is this canal, if do these two canals join together? So that's another thing. So there's a lot of things we're thinking about here. There's a lot of sorts of eventualities, and we just got to keep our wits about us. So we're going to do some glide path shaping in the palatal. We're going to do that to 0. And then once we've done that, we're going to make sure we keep patency, keep the irrigation in there, and then we're going to shape our master apical file in the palatal at 17 millimeters. And then as soon as we've kind of shape the palatal, I'm going to just try and check confluence. And when I irrigate and aspirate with my Irriflex tip here, what I do notice is that the two canals don't irrigate and aspirate together. So this is a kind of a maybe a possibility that they don't join. But again, I am always trying to keep my wits about me, because they could join, but it right at the bottom it could be like a calcification or a blockage. And once we remove that blockage, if it's a blockage, or we open it up by shaping both canals, this might then aspirate and irrigate at the same time. Always recapitulating, really important. And then we're going to shape the buccal glide path file to 0. This is at 19.5 millimeters, having a little feel around. And shaping relatively easy in these two canals. This really isn't the main talking point of the video, so I'm not really concerned about dwelling on this too much. But what I do want to say is, once we've shaped the two canals, there is a kind of beautiful type of symmetry we can see with this tooth. And if you're a member of our YouTube channel here, again, small monthly fee, and you get to see the access video, you can see one of the laws of symmetry is I think in this case showing that really this is got only two canals. And obviously we've shaped this out. The radiograph suggests that maybe it's two canals, and we shape the buccal and we can only see one obvious really big canal. Obviously I've got a microscope so I can see, but I'm quietly confident that this tooth has only got two canals. And again, like I say, you've just got to make sure you're very, very sure, because clearly if you miss a canal, then you're going to have open canal spaces that are full of bacteria, and this can cause failure. But that's blindingly obvious, isn't it? So now we've sort of ascertained that it's only got two canals. We're ready to do our cone fit radiograph, and I'm going to place the cone in the buccal canal in the first instance, but when I place this cone to length, it's getting a little bit stuck. It's not getting to 0. So what we don't do is we don't just fill it to where we've got. We're going to just recapitulate, irrigate in this canal space, and then we're going to just reshape with our master apical file. And once we've done all those steps and we've irrigated it out, when we place the cone fit back into the buccal, it fits really, really nicely to length. And that's really important, that you make sure you're obturating correctly. And as you know, by a lot of my videos, I like to snip off the excess of the GP point. We're then going to go for the palatal. Same again, we're going to fit the cone in our little measurer, but luckily this time when we push this cone to length, it fits really, really nicely and snugly to the working length. And then when we check the cone fit radiograph, we can see that this is clear now. Both canal spaces are completely separate, and these cones are to length, and the canals are centered down the center of the root. So the sort of outer surface of the root is concentric. So if, say, we had 2 canals in this buccal root, what we'd notice is that the one of the cones will be off center to the root, but in this case it's right down the center. Another tick to say that this has got this has only got two tubes or 2 canals. We're then ready for our final irrigation protocol. Same as ever, sodium hypochlorite activated, EDTA 17% activated, sodium hypochlorite activated. I don't tend to dry the canals in between because I'm just using so much irrigant in between and they don't really interact with each other. Then we're going to dry the canal space. It's all just simple kind of stuff, you know. We're then ready to obturate. Before I do, we need to prepare a hand file ready to introduce the bioceramic into the canal space. I measured it here to about 19 millimeters. And then I'm going to place this hand file into some disinfectant because don't forget this hand file's been inside a dirty canal and we've already cleaned this canal out. We're then going to use a bioceramic. Here I'm using 1 fill with these visco tips. Again, I've got high magnification so I can directly inject the bioceramic into this buccal canal. Once we've filled the kind of coronal to mid-third with the bioceramic, I'm going to introduce my disinfected hand file to almost to the working length, not always, all the way to the working length, and then just very, very gentle. What I'm doing is I'm introducing the bioceramic to the whole length of the canal and also reducing the risk of vapor lock. And then we're just going to very, very, very gently push the GP cone to length. And again, you know, I like to snip these GP cones off because I like to see the sort of bit where we cut off hit that reproducible point. This is the kind of point where we know we've measured all our our hand files too. So that's the GP into the buccal canal. We've got a little bit of excess, so we're going to cut that off with our heated plugger, and then I'm going to move back over to the palatal before we sort of tidy up that buccal canal, because I'm going to want to clean all that out before I have a little fiddle around. But what I like to do is I like to get a Mach 2 plugger and really push it down into the canal space and make sure you're compacting that GP into the canal space and you're getting all that sealer into the little nooks and crannies of the tooth. We're then ready to obturate the palatal. It's the same sort of thing. We're just going to directly inject the bioceramic into the coronal to mid-third of the palatal canal. Again, I'm using high magnification. This is a lot of sealer here, so you've got to be super careful. And there's an argument to say maybe I'm using too much sealer. As you can see with the post-op later on, we're going to introduce this file to almost the working length, maybe 2 to 3 millimeters away. And then we're going to just very, very, very gently push the GP cone in the palatal nicely to length. Again, looking for that kind of cut mark to marry up with the point that you've been measuring with your hand files when you did your working length. And you're not going to ram it down there. That's really, really important not to ram it down because you increase the risk of extrusion. So that's the palatal cone in place. We're then going to remove the excess with our B&L heated plugger. And then we're going to condense it down with our Mach 2 plugger. And that is both canals now obturated, but we're not finished yet. I'm just going to remove some of the excess sealer with a ultrasonic tip with the water on, but we need to remove a little bit more of that coronal GP. I want to just sort of cut the GP down so it's about 2 to 3 millimeters below the level of the CEJ. And the reason why I like to do this is because I then like to flow a restorative material in there to kind of plug it all up. But this is quite technically difficult to do. To remove the GP, it's quite tough and can be quite frustrating sometimes, especially get like little fiddly bits of GP. But once we've removed a bit of the GP for the coronal portion here, we're going to condense it down with a Mach 2 plugger, give it a little bit of a clean, and you can see now that this is really, really nice. This is neat, this is tidy, and we're ready for our final restoration. And what I do like to use is Scotch bond. So this is a self-etch bond. Trying to get bond inside a really small access cavity can be really, really difficult. So this sort of negates all that issue. And then we're using smart dentin replacement, which is a high flow bulk composite. And this kind of just flows into all the little nooks and crannies of the access cavity. And then when we look at our post-op radiograph, we can see that I have caused, I suppose a significant extrusion is probably, I'm being unkind to myself. I don't like to see this type of sealer puff, but in the end I know that, we've done our best. This isn't a massive extrusion. I'm not really concerned about any, relevant anatomy, say if this was near, like an ID canal. But overall, I'm very happy with this case. Again, it just demonstrates sometimes you just got to have a little bit of knowledge to know if it has got 2 canals or it's got 3 canals. And overall, that's it. Thanks for watching. Again, if you like these videos, please like and subscribe. If you have any comments or criticisms, or you think you could have done something better, then comments in the section below. Join the membership program if you want early access to content and exclusive content. And I will see you next week in the next video. Bye-bye.